All right, welcome everybody. It is 2 o'clock Eastern time on June 8th, 2023. And I'm very excited about today's speaker and the topic. Just a little bit of background. I've been very blessed to know Houston Park when I became a medical director at Palm Beach County Fire Rescue. And Houston's was there for over 30 years as a captain. And he came to Dr. Shepke with something that sounded crazy at the time, which was, hey, why aren't we treating these folks who had opioid use disorder? Why aren't we treating them instead of just having them do that circular door from the emergency department back to the street, back to the emergency department? So he came up with the idea, he came up with the program, and it's been so successful that he's now up at the State of Florida at the Department of Health. And its title is the Community Paramedic Coordinator for the State of Florida for the Department of Health. And I asked him, I said, Houston, can you come on and talk about what we're doing in the state of Florida with the Florida's CORE program? And so Houston, thank you so much for joining us. If you wanted to make any further introduction, and then if you want to share your screen and take it away. Thank you so much for joining us.
Well, great. Thank you, Dr. Intevi. I feel really privileged to have this opportunity to be able to join everybody here. I recognize quite a few names that are popping up. And just to begin with, as I share my screen, are you able to still see everything right now?
Yes, perfect.
Okay, great. So yeah, it's really exciting to work with Dr. Intevi, and just a little bit of feedback. So when Dr. Intevi came on board with Palm Beach County, I think it was right around 2016 to 2017, he was the pediatric specialist that came on board. And my passion was hazmat toxicology. And the reason I'm bringing that up to begin with is there's a connection to that and what we're talking about today. And so my passion was, I wanted to know everything that I could about toxicology, specifically that as it pertained to hazmat response, or the new realm, which was WMD, which is really just a nicer way of saying hazmat response. But I had created a series of protocols for antidotes for toxicology associated with WMD and hazmat, and handed that off to Dr. Intevi. And of course, he switched that to make sense with a Intevi model. And so that we had to immediately be able to look at something that made sense with calculating drug dosages for pediatrics that would fit into our realm of toxicology. So it worked out really well. And the reason I bring that up is because of the connection with my interest in toxicology. And we were just inundated with patients coming in and out of the hospital systems up in Palm Beach County at that time, as was the state and the rest of the nation, with overdoses, particularly those of opioids. During that time frame, Palm Beach County led the state of Florida with the most known deaths and overdoses opioid related. And so I wanted to find out, what can we do to change this? And I started doing a little bit of research, and I found that there had been a study done and had been verified through Yale and Harvard, where they were looking at the utilization of buprenorphine through some clinics. And these were walk-in clinics where individuals were given the opportunity to self-medicate, or at least self-direct for treatment on buprenorphine to get off of their dependencies to opioids. And so the statistics back then showed that there was like a 90% success rate on these individuals getting off with success of not needing to use any more opioids. And when I read that, I thought, there's no way that this could be possible. But I read it and researched it a little bit more. And so I presented it to Dr. Shepke. And he, at the time, was our medical director and also working at JFK Medical Center. And he was receptive to it. And so we created a program which really led us into the development of community paramedicine as it has become within Palm Beach County Fire Rescue. And it also was the catalyst to developing a program for treating patients that have opioid use disorder, and has now expanded into not only opioid use disorder, but substance use disorder as well. Unfortunately, that came at the end of my career. And so I worked a few more years on it with a passion. And I must say that at doing 30 plus years in EMS, I did start down in Miramar Fire Rescue. I developed a passion for the fire service and particularly EMS. But the most rewarding thing that I have ever done in my entire career was focused on working with patients with substance use disorder. And I've never seen anything like this. It reignited that fire of wanting to help people and seeing success in helping people. And so by doing that, I created this program with the help and support of so many other agencies and the willingness for doctors to go out on a limb and look at this and agree to it. And it works. And so about 2 years ago, Dr. Shupke asked if I wanted to come on board with the state at the Department of Health to help reproduce what we had done in Palm Beach County statewide. And the obvious answer was yes, I'd be happy to do that. So I'm really excited to tell you that we are actively working on implementing this same program, but with a little bit different roadmap statewide. Currently, we have 13 counties on board following this program. We're about to bring on another 12. Ultimately, we will have 65 counties on board statewide that will have a coordinated opioid response program. And what that is it is coordinating the efforts of fire EMS, the hospital systems, the behavioral health providers, and the federally qualified health centers statewide, the Department of Health, DCF, bringing everybody together, bringing them to the table, and establishing a system of care that is long-term care. And so I'm going to go into that. I don't want to do death by PowerPoint, so I'll get through the slides fairly quickly. And then there'll be a couple of points where I'm going to bring in some of the newest things that we're looking at doing, implementation of some of these new programs. And then what I would really encourage is upon the end of this presentation is having some open dialogue, encouraging anybody that wants to discuss what they have, what they think, what they see, or what they need, because that's where we're headed. Can everybody hear me okay?
Loud and clear, Houston.
All right, very good. Okay, so it's a network of addiction care, and I'm going to be cautious on using the word addiction care. One thing that I did learn when I stepped into this arena is the words we choose and how we speak to individuals that have substance use disorder is critical. And what I learned is how you talk to individuals that you're trying to treat. If you choose the wrong words or you choose the wrong way to speak to individuals that have these challenges, you will not get very far. And so I've learned how to change my behavior, to select my words properly, and to re-engage with compassion and care. So when we hear people refer to individuals as addicts, that's not a very nice way to refer to individuals that have a medical disease. And so I do want to encourage the thought process to change, and that we recognize anybody that does have a substance use disorder, that it is truly a medical disease. It is diagnosed, and it is now known in the medical community that it is a disease. So basically, it's a network of care for fire and EMS, and it's how to blend them together within the emergency services to the hospitals, and then on to a system of care beyond that. We already kind of said who I was. A little bit further, more information on it. Again, it's through the Department of Health from Tallahassee with direct encouragement and support from the governor. Also, we work very closely with DCF. So an interesting thing about DCF is that right before I retired, I was working with this program with Palm Beach County, and then upon retirement, I was asked if I would help support DCF in helping maintain or develop this program statewide. And they actually created a program called the Bridge Program. And so what this was a program where they were working with emergency rooms, and they were the emergency rooms were receiving patients that were being brought in by EMS. And the Bridge Program was a program to encourage the ER to facilitate induction of buprenorphine and then distribute or disperse the patients out to community behavioral health providers for long-term care. So many of the Bridge programs are still in existence, and those were funded through grants from the CDC. They continue to be funded at this point. So there's a lot of federal funds that come in. And in addition to that, we also work with the Healthcare Administration. So it's really it's a very big umbrella of support at the federal and state level. The goal here is to have a standardized form of treatment for substance use disorder. And although we have some definitive treatment plans for opioid use disorder, there are also some other definitive treatment plans to involve medications for some of the other substance use disorders. And so we'll include those as well as we go through this program. Here's kind of what it looks like if you were to put it into a diagram. You have an individual that overdoses. Emergency response and care navigation is provided. A model that's now being evaluated and utilized with success in Palm Beach County is rescues. And I'm going to use the word rescue because that's a common term in South Florida, but in other parts of the state, I'll use ambulance. They are bypassing the closest hospitals, and they are transporting to designated hospitals, ERs, that have specialized care for patients with substance use disorder, with physicians that are trained specifically in specifics to meeting the needs of patients that have addiction or addiction specialists. So they're transported to those facilities. Not much different than what we see with the development of a trauma system or a stroke facility or a cardiac facility. And that is becoming a trend, although that's not necessarily something that has to be set up right now. It is becoming a trend. And an interesting thing about this, and Dr. Shepke, he talks about this pretty frequently right now, and that is that, you know, when we look at the 911 system as we know it today, it started in the 70s, the early 70s, as a result of car accidents. Because there were so many frequent car accidents, it led to the development of trauma systems, because they needed a system of care that was going to focus on the injury patterns associated with motor vehicle accidents. And that's how we got our trauma system established. Well, now opioid injuries and death has surpassed car accidents. So when we start thinking on a global view of this, we need to start looking at what is the best way to treat the leading cause of death, which is now opioids, which has far surpassed that of car accidents. We need to have a system of care or facilities that can provide the best care for that. So then we go from there. We stabilize the patient. We start the medications that are appropriate, and then we transfer them to specialty medical groups that can maintain that medical care, and then focus in on the clinical side of that as well. Now, when I talk about specialty medical groups, it's not just about giving them the buprenorphine or the medical assisted treatment meds that are out there. It's addressing all of their needs. Do they need dental needs, or do they have hepatitis C? Do they have HIV? Because a lot of these things come together. Are there codependencies that we can start to address and get those taken care of as well? We also start to address the behavioral health issues. Sometimes the behavioral health issues are the reason that they have the codependencies to the substances that they become dependent to. So this is a kind of a diagram that shows the direction in which we are headed. A little bit of terminology for those that are not used to it. We will use the word SUD, which is for substance use disorder. It's recurrent use of alcohol and or drugs with a significant impairment. So somebody who experiments one time with a substance and ends up requesting or needing your services in EMS or the emergency room as an overdose doesn't necessarily have a substance use disorder. They had an overdose. And so what we want to look at is, do they have a dependency where they're using it inappropriately? Do they have a dependency to needing the drug? And I'll talk a little bit about needing the drug. And once somebody becomes dependent to a substance, particularly opioids or some of these other drugs that we're going to talk about, they need the drug. And the reason that they need the drug is because they don't want to feel the bad effects of not having the drug. And that's critical. We all have heard at some point or another in our career, oh, they keep taking the drugs because they want to feel that great high. Well, they lose that very soon. And particularly with the opioids, they use it. They have this great sensation. They get that dopamine effect. They feel like the best thing in the world. And then they come down off of that and they go into withdrawal. And that withdrawal feeling is so bad that they keep using the drug to get rid of that feeling. And then all they do is chase that feeling of not going into withdrawal. So we'll talk a little bit more about that as it goes on. We'll also talk about OUD, which is opioid use disorder. And I'll play a little bit on that a little bit later. And I'll talk about opioid use disease, because I think we also need to look at it that way, as an opioid use disease. And it's the misuse of prescribed opioids. And also want to include on that the synthetics that are so prevalent now, to the point now where if you looked at the state coroner's death reports, we're not really seeing anybody who has death determination by heroin, because it almost does not exist. It's almost completely synthetic, being that of the fentanyls that are out there. And they just keep redesigning the chemical chain of these analogs, and we're seeing less and less heroin and more of the synthetics, which is a challenge for us because many of these synthetics are less likely to respond to naloxone. And we'll talk a little bit about that as we get into it. So here's some interesting studies that have done on the effects of the brain disease and how when you use certain drugs, you can actually see there are true effects on the brain. And the same thing within different parts of the heart. And so we now know that when an individual is using drugs, the different receptors are attacked or used. But what they're able to show is particularly with opioids, it's not much different than a traumatic brain injury. The damage is there. And so once that damage is there, it takes a very long time for those neurons to heal or be repaired. And so that's why it is such a challenge with opioid use disorder to get the brain to repair. So you get somebody that does a short-term treatment, they've been removed from the dependency, but the brain damage is still there, and they resort to going back and reusing. Some people who go on medical assisted treatment may need to be on that treatment for the rest of their life. It all depends on the severity of the brain damage that has occurred. It's no different than a traumatic brain injury. And the same thing with conditions in the heart. We're seeing individuals that, due to overuse of drugs, have now needed to have different valves replaced within their heart. And these are quite challenging. So it's much more complicated than just somebody that has injected and then needs to go back and reuse, every few days or every day. The relapse with other types of drugs and illnesses is almost the same. So somebody that has hypertension that goes off their meds is more likely to relapse and have a hypertension event. Same as asthma, same as those dependent to substances and to diabetes. So when you see statistics like this, we've been taught, or we used to say the norm was hey, just quit using those drugs and you'll be okay. It doesn't work. We don't tell anybody else in any of these other categories, listen, quit eating the fat food and you're going to be fine. Your diabetes is going to go away. It doesn't happen. Your hypertension is going to go away. Some of the damage is already done. There's also the hereditary factors that play into that. You've already have the damage maybe with asthma. It's not going to go away, or it may become less, but there's still the damage. So we have to look at substance use disorder or drug addiction as the same thing. What are the main components of CORE? 24/7 accessibility, warm handoff from the ER to the providers. We're going to do everything that's based on evidence-based medicine. None of this is hocus pocus. Everything that we're doing is based on scientific backed medicine. And that's the really important thing. And then lifelong care and introduction into the population of healthcare that provides the patient with the best direction for the successful outcome. Now, I want to talk a little bit about the 24/7 access to care. With 24 access to care, when we started our program, which was we would interact with the patient in the field. We would take them to the hospital after a reversal with Narcan. The ER would see them. The ER would start their first dose of buprenorphine, or commonly referred to in the field as Suboxone. And then upon their discharge, a team member from Palm Beach County Fire Rescue would interact with the patient, confirm a date the very next day to meet them at their location. It may be where they lived in the woods. It may be an address, but we would meet with them. The next day, we would come and reevaluate them. We would give them their second dose of buprenorphine, and then we would schedule every single day after that for 7 days in a row. And what happens is when you give them that medication, it lasts 24 hours to 32 hours, which prevents them from going into withdrawal. And let me tell you, those patients, they showed up every day at exactly the time that they said that they were going to meet you. They were never late. They were never late because they didn't want to go into withdrawal. So when we committed to being on time, we had to be on time. And within the fourth or fifth day, they started to return to a normal type of appearance and functionability. And so after the seventh day, we handed them off to the healthcare district, who then continued with their care, addressed other medical issues, and then streamlined them into a long-term behavioral health care system. Now, I mentioned 24/7 because some of our providers weren't available on holiday weekends or weekends. And so sometimes the healthcare district would hand them back to fire rescue, where we would pick up those holidays. So when we looked at this, those are some of the things that we kind of had to correct on the fly as we were going through it. So MAT is a term you may hear out there. It means medication assisted treatment. The new term out there now is mobile integrated health, which is community paramedicine. Prior to the development of our program in 2016, I heard a lot of discussion about, this new community paramedicine program. And I'm being told that that is the future of EMS. But that was in 2016. I'm telling you, if you're not on the bus to becoming a community paramedicine provider, it is the future of EMS. Just like 30 years ago, if you weren't transporting ALS, you were going to miss the bus, and somebody else will do it for us. So something to consider. The creation of addiction stabilization centers or units, those are specialty hospitals that you transport to, and then getting your stakeholders and community partners involved is significant. The system doesn't necessarily require that you overdose, because you can have people call in and they can be given direction on how to get into this program, or who can serve them and help them the best way. And also they don't necessarily need primary care or psychiatric evaluation. Oh, they will need it, but we can direct them that way. So essentially what we're saying here is, don't wait till you overdose to call us. If you need help, we'll get you into the system of care that will get you the right care you need and put you in the right direction. I'm going to kind of skip over a little bit of this, but just some interesting statistics. We're still in a nationwide epidemic. COVID jumped up and took all the limelight, but opioid use death overdose is still recognized as a nationwide epidemic. And so the death rate is staggering. It actually is going up. The statistics here from 1997 to 2017, 400,000 people died from overdose. That's greater than 50% of the number of people who died from HIV. If you've been doing EMS for a while, I remember my first IV in the mid to late 80s was on an HIV patient, and I was terrified. And that's back when we did vital signs from across the room because everybody was afraid to touch an HIV patient. And now look, if somebody tells you they have HIV, we don't even blink an eye on it. And so look how far we've come in looking at that disease and how we treat that disease. And we need to start looking at how we treat this other disease that's been around much longer, but now we need to start treating it as a disease. We need to treat with compassion, care, consistency, and buprenorphine. And the reason I say treat with compassion and care, when we started this program, I was basically living 24/7 in the emergency room and running out and treating patients all over the county. And although we had tremendous success, and I actually was kind of beginning to be recognized by my coworkers throughout the department as the crazy captain that's out there now hugging the patients. And I'm not like that. I'm actually a pretty cold person. But what happened is we were working with peer specialists, and I was seeing that as soon as they interacted with their patients, they were touching these patients, they were hugging them. And I'm not encouraging that everybody go out and do that because, you know, we live in a sterile world now where we got our gloves on, we got our Tyvek sleeves, our mask, our goggles, everything. But what I saw is that there was some immediate acceptance from the patients to the caregiver. And the next thing I know, I'm hugging these patients cautiously. But what they said when we interviewed them afterwards was, yes, they really appreciated that we helped them. But what was most important was that we gave them care and compassion, and we made them feel like people. And so that was really significant. So don't be afraid to touch people or patients. It's called the power of human touch. This is just some statistics. I don't need to really get into too much about that. It's just staggering how many people are still dying with this. I can just jump through this because I want to stay on track with what we really want to go over. But anyways, we interact with patients that are overdosing more than any other community, maybe with the exception of police. And that's a really interesting topic that I want to talk about in a few minutes. And that is law enforcement is interacting with patients overdosing on a regular basis, so much frequently now that they're carrying Narcan in the field. And that Narcan, you know, used to only be something that a paramedic would give in the field in the pre-hospital environment, or it would be something that was given in the hospital. Never, ever was it given to a non-medically trained person or to a law enforcement officer. So it's become a very common practice. And so that's something that we are now challenged with because we have people who are being reversed as a result of an opiate overdose. And now what do we do with them? You don't let somebody that's passed out from drinking who wakes up sign a release and go. So how can we just say, oh, okay, you know, we know that you just got reversed. It's okay. You'll be all right. See you later. There's a lot of liability there, especially with the synthetics that are out there. And they're sitting there waiting to jump on a receptor that's been partially blocked for a short period of time with Narcan. And I'll get into that as we come along. But those are things we need to start looking at. And then also, you know, how do we connect with community? Go ahead.
Oh.
Is that a question?
No, that was a hot mic. I muted.
Okay. So, but we are going to interact with these individuals. So if you have a mobile integrated health program or community paramedicine, that you have patients that don't want to participate, you can refer them to your mobile integrated health program, and then they can follow up. When we first started this program, I went up to Ohio. They didn't have anything like this, but what they did have was a community follow-up program of non-medical personnel that would go to an overdose individual, their home or their location, and follow up with just checking on them. And even just checking on these individuals help them come back around. So it's that care. It's letting somebody know you care about them and following up on them that makes the difference. So again, the important part here is you don't have to overdose to receive services. And so there are many different ways to get people streamlined into different services. So other things to consider, we're looking also at substance use disorders. There's depending on where you are in the country or in Florida, we have areas where there are overdoses associated with opiates, but we also have significant problems with methamphetamine. That is a real challenge. There really isn't a medication you can give them that will help change their effects. There are medications that will help them sleep better and calm them down, but it is so destructive that it takes a lot more effort to help them. But there are processes that have been proven, that have been backed up in science, that we're starting to look at, especially those that are incarcerated, and they've had tremendous success. So, we're looking at what works now, what's saving lives, but we also want to address all of these other substance use disorders, to include alcohol. So in the state of Florida, there's 3 funded medical assisted treatment programs that support those incarcerated, and also that will support services that we're talking about. So you have buprenorphine or Suboxone. That's one of the medications. You have naltrexone, which has had shows great success in supporting patients that have substance use dependencies to alcohol. And then we also have methadone, which has shown success with those dependent to opioids. So those are the 3 funded medications. And then there's many other programs out there for helping get people off dependencies to tobacco, or I should say nicotine, and we can go into those a little bit later. But basically what we're looking at also is if a patient consents, they could even receive something as simple as a follow-up phone call. Now, I challenge you with this one. A lot of the population of these patients have pawned their phones so that they could buy more drugs. So if you try to call them, they don't have a phone. So that can be a challenge. And also, you have to be very careful about calling somebody's phone number and somebody else answers and not violating any HIPAA concerns. And Lauren Young with Palm Beach County Fire Rescue, they've come up with a really good way of screening somebody that answers the phone to confirm that that's their person that they want to speak to before they say, hey, we're just checking to see how you're doing after your overdose, because if it's the wrong person, it's the wrong message. So if you're going to do that, make sure you check into those right procedures on how to follow up with a phone call. Substance use disorder, we just talked about this briefly. I'm going to kind of quickly pass over that. How are we doing on time so far? We're looking good. We got about 25 minutes.
Yeah, we're good.
Okay. So 2/3 of the population that present with dependencies to opioids that are injecting drugs, and not necessarily just opioids, but if they're doing any other type of injection of drugs, are HIV and Hep C positive. 2/3. Think about the health impact on our community 20 years from now for an untreated Hep C patient. What is the cost going to be for those patients when they go into liver failure? Who's going to pay for it? What's the cost to the family going to be when they're in liver failure and they can't go to work? Or the continuation and spread of HIV. Both of these are manageable. So if we can get these patients into the realm of treatment, we reduce infection spread, we reduce the cost for unnecessary medical care, and we allow people to have a much healthier life. On the EMS hospital side for infectious disease spread, we make our job safer by reducing infectious disease spread or contamination. So I like to look at it a lot with this. My interaction frequently with hospitals, this was a big one on getting their buy-in to support it. Frequently when we would interact with hospital CEOs and we would start talking about, you're taking the responsibility of a patient that's uninsured, and they keep coming back because they have a dependency to an opioid use disorder or whatever the substance is, and they're uninsured, but you still have to provide that care. Well, if you treat them, in our evaluation of our patients, our first 30 patients we treated, we reduced hospital revisits by 87%. So the CEO or the chief financial officer of a hospital system is going, wow, we reduced the unnecessary return of a patient or readmission of a patient to a hospital by 87%. We're no longer eating that cost. And that's how, if you're getting resistance from a facility to buy in on this, that they may be more interested in supporting it, because now you're talking dollars, and that seems to be what drives the medical system right now, is dollars. So through trial and error, we learned how to navigate the system for the best purposes of the patient's outcome. And that's really important. So successful treatment involves a couple of things. Board certified physicians for medical care. That is so important, because up until now, I mean, particularly here in South Florida, we are a mecca for fake rehab facilities, and people are trafficked all over the United States to come to South Florida for care. And you show up at these facilities and they have no medical supervision whatsoever. And individuals are flown down here, typically maybe on the first round or the second round on their parents' insurance plan. But after they've expended that, then they've run out of insurance. So now they're on their parents' dime, which, these individuals, they know how to play the game, and they'll run them for 28 days. They'll overdose them, which gets them another 28 days of care. They'll overdose them again and kick them out. And now there's no insurance to pay for it. So, oh, we're sorry, you're not welcome here anymore. So then the family, as distraught as they are, they're willing to start paying the cost. And that very quickly depletes many people's savings trying to help their children. And so the problem is it's a scam. And the state attorney's office is working diligently to shut these down. And that has actually started to happen. But in the meantime, what we saw was there was actually no medical supervision or plan for these patients. And so by creating this core program and implementing this system, the system is run under a board certified physician. Appropriate medical care is given to these patients, and they're fed into a system of care, a long-term system of care that addresses everything, even to include that of behavioral health counseling, looking at their dental needs. If you see the patients that have significant dental needs, maybe what was driving their desire for pain relief was untreated dental care. We don't know why they're there, but more times than not, almost all of them did not say when they woke up, I want to become addicted to heroin today. I'm going to shoot up and I'm going to keep doing this. There was an underlying reason. I can't tell you how many people I interacted with that were there as a result of an injury they sustained while at war in Iraq or Afghanistan. They were treated through the VA, and then they were released because their injuries were healed, but now they were addicted to a substance they could no longer get. And they ended up using heroin on the streets only because they were buying OxyContin or whatever it was on the streets at $30 a pill. And then they quickly learned for $5 or $2.50, they could get heroin and get the same effect. and then pretty soon they lost everything. So we don't know why they're there or how they got there. It doesn't really matter, but the goal here is we can get them out of that position and get them back into a normal life by streamlining them into a system of care and giving them the right treatment. So medical assisted treatment for opioid use disorder has an unbelievable support. When they're given this medication, the ability to keep them from going back and reusing is consistently going up. You're going to have patients that will fall off. It doesn't mean that that's the end of the program and they're done. It means they had a bad day. You bring them back, you start over again. And we ran into that occasionally, but not a whole bunch. Our success stories were there were so many. That's what kept driving the team that we created to keep going back out and interacting with these patients. So the science is there. It speaks for itself. The medication, so buprenorphine is a partial agonist. And basically what it does is it sits on the receptors, these pain receptors, and it blocks the effects of an opiate. So the opiate can't even attach to the receptor, right? But it's partially there, and with the buprenorphine mix, it allows the body to still have that feeling, but not go into withdrawal. And that's the important thing. Whereas if you give Narcan jumps on completely as a complete agonist, blocks the receptor so that no good feeling occurs. And then the patient starts, when that wears off, goes into withdrawal because the Narcan is worn off. They still want that feeling. There's nothing there that's stimulating their brain to saying, hey, I feel good. And that's when they go back and they reuse. That's the very basic science of it. I could go into it in great detail. I don't need to right now. But what we want to prevent them from doing is going into withdrawal. And so in withdrawal, we talk about assessing the patient to determine what level they are. I'm going to skip through this because I want to go to the newest way of looking at it. I already mentioned this. This is buprenorphine. I'm going to talk about this a little bit more in detail in a second. So standing orders, I'll go back into this in a minute, but anytime EMS is running on anybody unresponsive or unconscious, as long as I've been doing this job, and I recognize a few people in this program today, they've been doing it as long as I have or longer. Narcan's always been one of the first lines of drugs for an unresponsive patient. So we get false information on why is Narcan used for opioid overdoses versus an unresponsive patient. But it's ABCs. We want to determine if they're having a seizure, stop the seizure, any cardiac related or poison. And if it's a poison, do we have an antidote? There's very few antidotes that we actually have in reality out there anyways. So when we start looking at narcotics, this is a protocol that started to be utilized in Palm Beach County, and I'll zoom in on this more in a minute. But let's think about this. One of the bullets that I provided to Dr. Intevi, and it's one of my pet peeves, is so Narcan, we know, is a reversal, right? It's not an antidote, it's a reversal. And my son is a paramedic now. I'm very proud of the fact that he's followed in my footsteps, and my next son is starting fire school next week, and he'll be doing the same thing. But you know what happens is fire stations or zones, they create kind of like a way that they treat patients depending on where they are in the culture. And when he was going to paramedic school a few years ago, he would come to me and say, Dad, he goes, all we ran were a bunch of overdoses, and all we did is slammed Narcan all day long. I about lost it because that's not what we do. And we don't slam Narcan because it's not what it's designed for. We give Narcan to keep them breathing. That's it. We don't want to wake them up. We want to keep them breathing. If they're breathing and they're breathing sufficiently to maintain a good SpO2, good. Don't wake them up. Nobody wants to clean up vomit. Nobody wants to fight them in the back of the rescue or the ambulance. Nobody wants to take a unruly patient into the emergency room because you've slammed them with Narcan. What are we seeing in the field with law enforcement and the civilian population? 4 milligrams, 8 milligrams of nasal, rapidly absorbed Narcan, right? How are our patients presenting to us? Combative, sick, and immediately in acute withdrawal. That's why they're leaving. That's why they don't want treatment. They don't feel good. We've just turned their bad day into their absolute worst day. And then the police don't treat them well. We don't treat them well. The hospital doesn't treat them well. No wonder they leave. Plus, they don't feel well. So if they're breathing, it's sufficient. We monitor them, monitor their O2, provide bag valve assistance as necessary. If they're not breathing enough, bag valve mask, support them. Go back to your old school theories of Narcan. You could even consider some IV drip administration if you can get an IV, and it's a patent IV, where you're going to go ahead and dilute Narcan at 0.5 milligrams of Narcan into a 50 ml bag, and basically of saline, and you're just going to kind of run it wide open in a 60 drip set and titrate to effect. We're just trying to bring back that respiratory effort. The other side of the fence is you've been presented with a patient that's been given a full dose of Narcan and they're awake and they're combative. This is where we can start to talk about, hey, we have this medication called Suboxone or buprenorphine, and we can give it to you and it will make you feel much better. And the trend now is what we're calling it is pre-induction or pre-hospital induction buprenorphine. And so what's happening is if you get consent from the patient, you give them the buprenorphine. Usually it's going to be 16 milligrams, and it's a buccal administration. It's a film. So it's absorbed in their mouth, usually 2 strips of 8 milligrams. And what this does is it's rapidly absorbed, and it takes away that acute withdrawal sensation that they're feeling. It calms them down. They're no longer going to be vomiting. They're no longer going to want to fight. And now they're receptive and open to receiving treatment when you take them to an addiction stabilization unit for definitive care. And that's the trend. And that's what we are going to see start to flow. So the Department of Health under Dr. Shupke's direction and Dr. Latterpole, we're not saying this is what you have to do. We're saying this is an option. And they've had tremendous success in New Jersey, Connecticut, California, and a couple of other areas where they're actually doing pre-induction buprenorphine. And in some cases, they're not even going to the ER. They're stabilizing the patients. They've induced them on their buprenorphine, and they're setting them up for a system through their community paramedicine where they get follow-up care the next day and the following day, and then directly into a system of care. So that's the future I see of EMS. Here's some concerns with rapid administration of Narcan with some of the analogs that are out there. Acute PE, pulmonary edema. It puts them in withdrawal. The old school, 2 milligrams. The new school, 4 milligrams, 8 milligrams. That doesn't work. I mean, it wakes them up. But the newer school, or the new age school, I should call it, is this dose right here of 0.1 to 0.4. When I went to school, as many of you, our dose was 0.4 milligrams, okay? So the old school has always been there. It just got changed. So go back to the basics. That's what we're here for. I just kind of zoomed in on this so you could see the different administration routes. IO is great if you can't get an IV. And the reason I talk about having a patent IV is because they've probably blown most of their IV sites, so be careful with that. This is worked with this with Dr. Phillips. She and I came up with it as Dr. Shupke encouraged that we have a visual flow chart so that paramedics can really kind of have a flow chart on what to do and talk about a CALS assessment. So the clinical opiate withdrawal scale is a scale that we use to determine at what level of withdrawal are they in. And basically, it's kind of like doing an APGAR scale. And how many of you remember how to do an APGAR scale when you're delivering a baby? Right? And I'm not even going to go into the acronyms that we've learned on how to remember it. But I can tell you that most people don't remember the number, and they've got to pull out the Hantevi score or the whatever the scorecard is that you use. You figure out what the APGAR is. But look at this way. Some of these questions are subjective, and so you got to be very careful. So you look at the respiratory rate. Those are something that we are used to assessing, and you base it on, is the pulse rate 50 or below? They get a 0, whatever. So those are you assign a number to the rate, and then you look at things like, do they have chills? Okay. Now, if you ask these patients that have truly been using these drugs for a while and they've had an assessment like this, they have studied for this test and they know the answers. They know how to get the best possible score to get the best amount of medication. So you don't ask them if they have chills because they're going to tell you yes. So in this case, you evaluate them to see if they are currently presenting with chills or goosebumps. Okay. Are they agitated? Can they sit still? Go through these scores, add up the numbers, and then you're going to determine, are they mild, moderate, moderately severe, or more than severe? And those numbers will then determine roughly where they are in withdrawal. And this is how we determine whether or not they're a candidate to getting buprenorphine or not. And these are the ways that we move into going with basically, if they're less than 7, we're not giving them buprenorphine as a pre-hospital induction. If they're greater than 7, we start at 16 milligrams. It's really that simple. But you have to. Go ahead.
Houston, I have a question. This came up yesterday. Somebody asked me this question. I didn't have the answer. We used to say 4 or 8, and then suddenly it just became 16. Can you kind of, is that because we want to give them a longer tail so that they don't rebound or go into withdrawals earlier? Is it just giving us more time at the end? Can you explain that one?
Yeah, absolutely. So they've come out with new scientific studies and data because of the analogs and the strength of the fentanyls that are out there, that the higher dose buprenorphine is more appropriate to preventing them from going into withdrawal. And that's exactly why the numbers are where they are. 16 was the max dose when we first started the program. And now it's pretty much the loading dose. So we have about 5 more minutes, Dr. Antevi. Yeah. So I'd like to open the floor to questions and answers.
Perfect. So we do have a few people who have sent me personal text, but let's see if Elizabeth, and then I have some people I want to get Dr. Miramontes in, and maybe Dr. Lahner if he's willing. But Elizabeth, can you unmute your mic and ask Houston your question?
Thanks, Peter. Hey, this is Libby Char.
Oh, it's Libby. Not Libby. It says Elizabeth. I'm sorry. Duh.
Wondering, a lot of it is dependent on passing the patient off from once the treatment's initiated in the ED into the community programs. Did Florida have to stand up additional community treatment facilities to hand the patients off to? And if so, how did you get the community to increase the treatment providers or programs? Great presentation.
That's a great question. They were pretty much already established throughout Florida because of the participation with DCF. And in Florida, they divided Florida into seven different districts. And there were these organizations that were funded to provide community health, behavioral health providers. And with that, they received funding specifically from the opioid settlement funds and the CDC to fund medical assisted treatment and long-term behavioral health care. The challenge was finding those organizations and then linking them to the providers, but they're there. And that those federal funds are available nationwide. It's just a matter of going out there and finding out where they are. Did that answer your question?
So
Yeah,
Libby,
thank
it's Miramontes. That's exactly you have to pay them, right? If you want people to treat your patients, they got to be paid for it, especially if you don't have expanded Medicaid like we have in Texas. You got to pay them and then they'll come.
But see, the funding is there. These organizations are being paid. You just have to figure out who is being paid and then go collect the service. Because a lot of people are sitting on the money and they're not using it.
And you mentioned CDC funding.
Yes.
Thanks.
And it's called SOAR. It's State Opioid Response Grants.
So let's see. I know we have a few other questions, but Houston, my question is, I just wanted to kind of overall clarify for myself and for everybody. You know, in Palm Beach, we have JFK, which has become our ASU, right?
Yes.
Our addiction stabilization unit. You know, unfortunately now that place is only open 12 hours a day. And it's hard to tell any EMS system to go to that place only during business hours. And I know that we're trying to expand that, right? Palm Beach County is the largest county east of the Mississippi. And it's hard to drive umpteen miles across town to one location. So with the core program, is it the state's intent to open up more ASUs so that people can then funnel into those locations and get the full wraparound service? Is that the goal for core?
Absolutely. The goal is to have as many providers as we can within that established system. And then also, as we start to really look at this and evaluate patients that don't need to necessarily be seen in an ER, and then those patients could be then induced pre or non-hospital and then streamlined into a system of care.
Okay, so I want to get Dr. Lee in a minute, but I have a few follow-up questions, which is, you know, I tried starting this as an individual agency with an individual hospital, and where everything broke down, Houston, was that once that handoff happened, and like I'm looking at Dr. Montes on the screen because San Antonio does a really great job of like somehow passing the baton off from EMS, and then once they go into that hospital abyss, that patient oftentimes get lost. So you have a lot of people on the call today from the state of Florida, from beyond the state of Florida. Do you recommend that they follow the path of a statewide program, or like in Miramontes's place, a huge city or county-wide program, rather than kind of going in it alone? Meaning that I'm an EMS medical director, I want to make this happen, but I can't, beyond giving the 16 milligrams, I'm probably not the guy to go ahead and figure out the community service and all the follow-up wraparound services. Isn't that the state's responsibility, like what you're doing here?
I would say it is the state's responsibility, but you know, I have found success working out with so many different organizations. I mean, it may not come across to you guys that I don't really have an ego, but what I'm going to tell you is we had a meeting with the biggest organizations and the smallest. And my words were, leave your egos at the door, come in and let's put something together. Let's not meet to meet. Let's bring people together and make something happen. But it takes, I mean, Dr. Tevi, it took us 2 years to get our program up and running. And then it falls apart and you start up again. So it's constantly a challenge. I would be happy to help you guys get up and running in Texas or anywhere else. Anybody wants reach out to me through either Dr. Tevi or through an email on this. I'd be happy to help kind of, you know, connect the dots.
Awesome. And there are people, and I am going to give you your email in a minute, if that's okay. But Dr. Lee, thanks for coming on. It was great to see you.
Thank you, Peter. You know, this is probably a very simple question, but I know somebody else asked something about xylazine. First of all, Houston, great presentation. Thank you so much for what you're doing. Appreciate the leadership. Let me ask you something. With so much of the fentanyl today being laced with xylazine and not responsive to Narcan, and yet we have no way of knowing that that's the case, and we have somebody with severe respiratory depression, how do we avoid, you know, as you might suggest, overdosing them with Narcan?
So
You understand my question?
Yeah, absolutely. So xylazine, first of all, is now seen in 48 of the 50 states, and is becoming more and more prevalent as being cut into fentanyl that's out there. And you're not going to get any response with Narcan, as you just mentioned. And so what I would suggest is if they're non-responsive to your first or your second dose of Narcan, then let's just say, what if you didn't have Narcan to begin with and you had respiratory depression? What do? We manage their airway either through BLS measures or through ALS measures. And so if all else fails, the best antidote for any respiratory arrest is we manage it to our best of our abilities, either with pharmacology or through the basics, which is, just an OPA or an endotracheal tube or anything in between. Those are our best answers. And those, as long as you do it right, you could have all the xylazine on that you want, as long as you maintain the airway and the other vital signs, it doesn't matter.
So you're suggesting that we have a definite stop with the Narcan?
Oh yeah, because it's not working, and they're gonna just waste time doing it, or it could make something worse, such as acute pulmonary edema, and then now you're challenging your patients with fluid now in the lungs as well. So.
Okay.
But Houston, I want to follow that up just because this is a huge question where people say, oh, well, because of the type of opioid that's out there, we just need more Narcan. That's kind of like the common theme that you hear. And then you have, like what we're doing in Palm Beach County is that we limit the Narcan and we focus more on the airway. So can you talk to that about, are there certain types of opioids out there that would respond to 4, and 4, or what you're saying is you give 4, you give another 4, it's over, and let's just continue with the airway management.
That's what I would recommend. I wouldn't keep chasing it, because the longer you keep pushing the Narcan, the longer that person's going without breathing. And I would be more. There's a lot of studies that show just by providing ventilation, it stimulates the respiratory effort on its own. Patients may start to breathe on their own anyway. So
because their PaCO2 is probably like 70.
Exactly.
You got once you breathe them down, they kind of wake up.
Yep.
Dr. Lee, did you want to have a follow-up? Because I want to also bring in Dr. Miramontes as well.
Oh, no, I'm good. Thank you very much. Good to see you.
Thank you, Wayne. All right, so David, I'm so happy that you're here. I always say that the folks in San Antonio, led by Dr. Miramontes, they probably do the best that I've seen in any agency around the country in kind of attacking a problem from its core and providing all the wraparound services. So David, I know you guys have been doing this very well. If you wouldn't mind spending a few minutes and telling everyone, what have you been doing in San Antonio? And then I would like to hear Houston's comments after that.
Yeah, so we started with grant money. So the School of Nursing, actually, not even the fire department, got all this money and they couldn't deploy it. And so they said, no, the fire department, you're pretty good at doing stuff. Let's see if you can do it. So that's how we got started. So what we did is through our RAC, or Regional Advisory Committee, otherwise known as a Healthcare Coalition, we started a consortium, and we have different agencies that contract in to provide this service. So we do then Narcan outreach. We try and see everybody that has overdosed the day before. If they're in withdrawals, we provide Suboxone. The hardest thing that you've talked about is navigate them into treatment. That is the hardest option. Do they have insurance? Do they don't have insurance? Are they homeless? Are they not homeless? Do they want Suboxone with a prescription? Do they want to go every day for methadone or Suboxone? And that's the problem. You got to have a place for them to land. If you look at the New Jersey article, they used a university clinic. They were 46% effective on getting their people who got Suboxone the night before after an overdose into treatment. That is amazing, right? Usually in the addiction world, you're happy with 1, 2, 3, 4, 5% that navigate. So the whole goal is find out in your community who's doing this work, how can we get them there, and pay them. Right? If you have a grant, if you have public health dollars, you have you have the opioid dollars, get them paid for some of these patients that aren't insured. If you have expanded Medicaid, this is even easier because they'll pay for it, right? So it just depends on your location. Find places where they can go. The X waiver's gone, folks. Anybody can prescribe. Yeah, anybody can prescribe, but they still need the backup supports. They need peer counseling. They need the mental health. They need all the other services. But anybody with a DEA license can prescribe buprenorphine. Find that person, whoever it is, or that clinic. Leverage your public health people. Leverage your university or your residency folks. The psychiatry residencies. Leverage. Get a place for these people to land, and let's save some lives. Because you can't save someone if they're dead. So let's keep these people alive. Let's get into a treatment. Let's do some transformational medicine. And it's all about taking care of patients.
Awesome. Great words. Houston, comments?
Well, I feel like I'm watching a live version of Forrest Gump because I literally lost connection and all I heard was what you just said at the end, which is like, that's all I have to say about that. So
Yeah.
I do want to mention one other funding source that's out there. And that's so true about, also PAs and nurse practitioners. They can also write, like you said, if they have a DEA license. But using federally qualified health centers, they get the medications for pennies on the dollar. So FQHCs throughout your community, you can tap into that as a much cheaper source for the medication. But I would like to hear more of what you're doing out there in San Antonio. I just missed it, but I don't want to take up time from anybody else.
They're doing everything that you're talking about effectively, but they have basically contractors that they've paid, like that's what he mentioned before, pay those people to provide all of those services. But he mentioned that the hardest thing is getting those patients navigated into those area, into, beyond that induction, getting them navigated in. And I wish you guys can get together because they've done it so well because they have a regional, they call it the STRAC, the San Antonio or the South Texas. What's the STRAC, David? What does that mean?
South Texas Regional Advisory Council. It started out as a trauma thing, but we do all phases of healthcare, including MIH. You name it, we do it. That's so it's a 22 county consortium that does everything together. And they do project management, they manage the money, manage the process, and they provide a place for people to meet.
Awesome. So Houston, let's get practical. There are folks. I'm looking at the names here. There are, you got Dr. Lee who takes care of a very large area of Florida, Chief Gunn and other people. There are 13 counties, I believe, that currently have a core program, right? And you guys are moving to 30, right?
Yes.
So if you open up a core, an ASU, if you will, in Broward County, first of all, is that coming to my county here in south of Palm Beach County? And once that happens, is the expectation for all of us to then, like you said, bypass, go right to the A. So all of us have Bup 16 milligrams pre-induction, go to the ASU, and then the ASU will have those wraparound services that the state is gonna help kind of provide. Is that the whole thing here?
So I don't know if Broward is the next one on the list, but
it's not. I didn't see us on the list, but let's just say we were next. Fine. Yeah, I know we're coming, but I'm just giving you the what if. Would that be the expectation? So to then drive everyone there.
Yeah. So there's a whole flow chart of what they're looking for, and you all would meet probably 19 of the 20 requirements if you didn't already have all 20. And so the goal is that there would be funding to help support the system. The only thing that's not funded right now is the funding to pay for the medication. However, there is so many millions and millions of dollars coming into each county through the opioid big farm settlement that DCF is mandating that part of those funds goes to paying for buprenorphine through EMS. So nobody should be short of any money paying for these services. There will be roughly $1 million funded into each system of care through this core program just to kick it off and keep going. And then there's projected over 16 years of sustainment beyond that. So And I mean, it's a system that's constantly building and being reevaluated. But
so as far as the EMS programs today that are not doing this, would you say for us to ramp up towards getting a BUP protocol with teach people the cows, et cetera, get all that into the protocol so that when it comes to the county, we're doing that initiation phase of getting those people who are having withdrawals, who can get the induction dose so that EMS is ready. Is that kind of a good first step for agencies in the whole state of Florida to say that should be our next first step, because the next step will be handled by others downstream?
absolutely.
Okay, perfect. Are there anyone else? I know we have we have folks from here we go. Let's see, Teresa. Can you want to unmute your microphone, Teresa Bowden? Thank you for your question.
Can you guys hear me okay?
Yes, we can. Thank you for joining us.
Oh, it's been a wonderful presentation. I'm completely engaged, 300%. So I'm actually zooming in from Spokane, Washington, and I'm involved a little bit with some research with medication-assisted treatment. So my question was just starting the induction with BUP, and then at some point, I'm assuming they will transition them to like Suboxone for their long-term treatment.
Or Sublocade.
Okay, yeah, excellent. This has been wonderful. I cannot wait to share this with some of my colleagues. I thank you so much for your work that you've done. This is really fabulous.
Oh, you're welcome.
Awesome. Very nice of you. Thank you so much for your question and for joining us from Spokane. Anybody else? I see, let's see if Dr. Launer, you are on, and I know you're in the Baltimore area. And tell us your thoughts on this and where you guys are in your county.
So first of all, how are you? It's so good to see everybody. Thank you for the time. We're always following in those Florida footsteps, and obviously in a very nice soil of San Antonio. Anyway, it's really good to hear this because our challenge, Baltimore brings a lot to the table in terms of challenges. We have the opiate overdose and epidemic is persistent. But the linkage to care problem is our, quite frankly, biggest challenge. The Maryland State has come up with a buprenorphine protocol, which I think mirrors a lot of what you're talking about. Our challenges are, number one, coordinating the linkage to service, which I think you've already addressed. And then number two, quite frankly, is transportation, because our opiate refusal rates are about 46%, meaning of people that have overdoses, they're not contemplative, they're not ready to sort of receive this brief interventional counseling. And then a lot of our patients that have homelessness, housing challenges, mental illness, we can't physically get them to places that are open. So I think as we mature, this seminar is definitely reiterated and emphasized key points, but certainly I would love to hear more about the linkage to care, because I think that's a big focus, especially for us in Baltimore. We do plan for full disclosure on going ahead and applying, and I think that's in no small part to the efforts that you all have done. So once again, my thanks for the feedback.
So couple of things that we did to get around that. One is there's some agencies that are doing mobile buprenorphine clinics through their departments of health, and then funding Uber Health. So Uber Health is a part of Uber where the Uber goes to the patient, picks them up, takes them to a facility for their treatment, waits for them, and then takes them back home or wherever they're living. So, and those are funded through a system. And then there's a couple of other ways where we've established treatment areas, particularly in the areas that are difficult where public transportation is not available. So those may help you with those challenges.
I wanted to follow that up. Ben, thank you so much for the question. And Houston, that was a great answer. I have a quick question. So part of what I've learned is that you need some sort of software to coordinate everybody. Is there anyone that you would recommend? Pulsera, there's Julata. Well, what are your thoughts on that while I take this phone call? Sorry, go ahead.
I'm not real up on the different types of software. Every once in a while, somebody will ask me to sit in on one, and it goes in one ear and right out the other. So I would defer that to somebody else.
No, and I'm only asking because, we had a call yesterday with a healthcare district, and the question becomes, we all want to measure what we're doing, right? We all want to say that John Doe that we had in our back of our ambulance today, we sent him to this hospital or to this ASU, who then went to this specialist and got this therapy and got all the wraparound care. I want to be able to know that, in 6 months from now, that we had, in other words, I want all that data from the total number that went in, how many matriculated through the program at 6 months, how are we doing, et cetera. So what is the state's data plan so that we have this information and we can see that this is actually working, so we can really continue to promote the use of it?
Oh, okay. So yeah, so the state does have a comprehensive data plan. So right now on the EMS fire side of it, they're using MSTAR, and they're collecting that data. And then those that are participating in CORE agree to provide certain types of data, which is a challenge. I mean, if you can imagine looking at the hospital systems that were, let's just look at like the Puerto Rico, Florida stroke data that was such a challenge to get shared. But if they're participating in this program as a core member, we're looking for them to do BAM measurements. And then the long-term providers are providing BAM, which is a measurement of, it's not necessarily used in EMS, but it's a way of looking at reoccurring use and treatment. So you can follow a patient from start to finish, which is, we need this data to know what's working and measure what we've done. And the only way to do that is to be able to look back. So,
right, but so Houston, from a practical matter, we, for example, in Palm Beach County use Metro PCR. In Broward, we use ESO.
right.
We have the patient, we plug him into our thing, we give him the bupe, we let him go.
Uh-huh.
How is the state going to say, okay, they were in the back of this ambulance, this patient started here, they went to this hospital, they got therapy the next day by mobile integrated health, they went to this, you see what I'm saying? Like what these other software platforms do is they actually, through one platform, they say, okay, once you say go, these 15 people are notified. And then as the patient navigates through, each of those people put in the data. I did this, okay, they did that. And then you can look at the summary of this person's care through a 6-month journey, if you will, that they exited the program and now they're on Suboxone or whatever they're on for the next 10 years. But they're a success, right?
Right.
Versus the patient who came in once, he failed, came in again. Like I just haven't heard yet, and maybe it doesn't exist, but I haven't heard yet, like, how is all that data going to be displayed in a way that we could see how is Davie Fire Rescue doing, and Coral Springs Fire Rescue, in Palm Beach County? Each of us who are just a lowly medical director who treats patients off the street, how are we going to go back to our city commission and say, we're doing a great job? Where is that data going to be given back to us so that we can say, hey, we should keep this going? You see what I'm saying?
So we're using a program called Essence, and I don't know enough about it. I don't want to misspeak, so I will speak to the people who are working on that, but I know that is a common discussion at the state level. And I will get that information or put the right people in touch with you, because it is absolutely necessary that we have that type of information.
Right. And the only reason I ask is because, when we tried starting in the Coral Springs, unfortunately, COVID derailed everything because we were about to start. I had DCF was going to give money for us to use this piece of software that we found that was good, called Julata, whatever. And I know David and them use a software called Pulsera. But I think either way, it's patient care navigation beyond just the silo of your institution, whether you in Spokane as a researcher, or you're Peter Antevi, a medical director, or you're the medical director of the emergency department. You see what I'm saying? Like, we just have to be able to connect all those dots. And I think that's part of the challenge with these patients, is not just, here's your prescription for your pneumonia, and go to the pharmacy and have a good day. It's 10 or 15 other things in a patient population that, you know, isn't initially wanting to maybe play along because maybe they're not so eager to take that journey just yet. And maybe it takes till day, like you said, day 3 to 5 until they say, hey, you know what? These are caring, compassionate people, and I am going to continue that journey. And then you're able to continue to follow them. Anyway, maybe just food for thought that, you know, anything we do, we try to measure, as I'm sure you know that. But I'm just curious as to what platform that would look like along the way. So, and someone just has a chat here saying, Eric Hernandez says biospatial can help him. Biospatial is a great idea, actually, because they you know, with biospatial, it's basically a data crawler, and they crawl data from ESO, they crawl data from ACA, from the hospitals. So Eric, are you at the state? Eric, are you at the state? Are you with biospatial? Can you unmute your mic and maybe help with that?
Hey, no, I'm with Miami-Dade County Fire, but we're currently in talks of using it for other things other than just cardiac arrest, to track data and be able to do that, because we're trying to develop our own community paramedic.
Okay, gotcha. Well, thanks, Eric. Yeah, we actually use biospatial thanks to Tom DiBernardo. He's kind of, you know, I use it quite a bit for all the NEMSCO measures and the FAIR measures, et cetera, the Coverdale measures. But it would be interesting to be able to take a single patient or a grouping of patients and say, you know, all the patients at Coral Springs Fire Rescue entered into the core program, you know, have successfully exited, if you will. But I have to think that I know that the healthcare district with Dr. Andrich, who's done an amazing job, she does track that. So she does have dashboards because it's all coming into the ASU. And once it comes into the ASU, they have the ability to track. But I have a feeling they're using disparate data sources and a lot of phone calls and manual labor to find out who is actually has been successful in the program and who hasn't. So excellent. Well, I know that we're 25 minutes over time, but Houston, that was an incredible presentation, and I really learned a lot, and I really hope that many people watch the video. But before we leave, is there anybody else? I see Dr. Zuber from Orlando. I see several other names on this list. Do any of you all have questions or comments before we end? And if we don't, Houston, I'm going to give you the last word. So what are some of your final comments to energize us and to, you know, make us want to go out there and do this?
Well, first of all, thank you very much for everybody spending an hour and 30 minutes with us. I really appreciate that. What we are doing does make a difference. I gave a presentation last week in Orlando for the Department of Health, and we had a person from the CDC come in from Atlanta, and I was honored to be able to tell this doctor that Florida, Philadelphia, and California, particularly LA, are the trendsetters in EMS, because we were the beginning of it and we continue to be, and this is the next trend. So being at the tip of the spear is the best way to make things change, and we're making them change. And I was fortunate to learn my EMT and paramedic skills from a guy that's no longer here, Randy Boaz. And he taught me back in 1984 that if we can't treat people like people, then don't treat people. And so I've tried to do that my whole career. And when we get tired and bored and upset because we've been running on somebody so many times, just put that aside and remember that they're still people. They're somebody's parent, brother, sister, son, daughter, and we just got to do our best to treat them. So we'll fix this epidemic. Thank you.
Words of wisdom. Houston, you're a special man. Thank you so much for your time today. And I'll be sure to let everybody know when this recording is available. So Excellent. Thank you again. And thanks everyone for joining us today. Have a great day.